Okay, today's topic for office hours is aerophagia. And aero means air and phagia means swallowing. So aerophagia refers to air swallowing. And here's the deal. We all swallow some air during the natural course of the day with eating and breathing and moving around. We swallow about 2 quarts of air a day. But most of that gets expelled, about half of it from above in the form of burping and about half of it from below in the form of flatulence or farting. And most of us don't have any trouble dealing with that 2 quarts of air. So aerophagia refers really to 2 things. So people who are swallowing more air than usual and ending up with more than 2 quarts of swallowed air, or people who are uncomfortable with the amount of air they're swallowing, even at sort of more physiological levels. So let's talk first of all about the symptoms of aerophagia, and then I want to spend some time talking about the physiology, the causes, and then finally we'll wrap up with a treatment. So the 3 things, I like to think of them as the 3 Bs for aerophagia, and that is burping, bloating, and belly pain. And it's I was practicing this all day yesterday for you, the kind of swallowing. So I'm going to attempt to demonstrate my air swallowing. That wasn't bad, right? Okay, let me do it one more time to show you. So I'm swallowing. Now, you'll see that when I'm swallowing air, I'm making a very conscious effort. I'm going, try again. Not so good the second time, but the first one was kind of fratty, like a little bit of a frat boy burp. No offense, please, for anybody on the call who is a member of a fraternity, but you can see that there is a mechanical aspect where I swallow the air as opposed to inhaling it. It's going into my stomach, and then I'm able to burp it back out. And I'll tell you that when I first arrived at Georgetown on the faculty in 1997, I had a really lovely patient, an older man, and he was really plagued with aerophagia. And it turned out in our evaluation that he had a deviated septum. He was mouth breathing a lot, and he was also dealing with some anxiety, and he had started breathing in a way where he was swallowing a lot of air and unaware of it. But he was really troubled by it. And when I first saw him in the clinic, we talked about some things, and I told him that I thought I knew what was going on, and we had a plan, but I don't think I was moving fast enough with a plan, because he left me a voicemail. So this is, back in the days when patients couldn't really email you, but they could call you. He left a voicemail on my line at the hospital that was literally 7 minutes of him burping. So he wanted to impress upon me that this was a really serious problem. And I saved that message for several years. And then finally, I don't know what happened to it, but it was literally him going over and over and over again for 7 minutes. I did it pretty well that time there. So let's talk about what causes aerophagia. There are 3 main elements of this. And let's start with the mechanical. So again, I said we all swallow some amount of air when we're going about our daily business. But if you are talking faster than usual, you're more likely to gulp in some air in between sentences. So talking fast, eating fast is another one. Eating and talking is a big one. So if you're eating and you're sort of chewing down and you're also talking at the same time, you are much more likely to be swallowing air. Talking on the phone and eating for some reason, and sucking through a straw. So I like to use my water bottle, as you can see here, has a straw, and I like to drink from this. But that sucking motion with a straw, you pull more air in, believe it or not, when you drink with a straw than when you sip. And so if you are in the habit of drinking with a straw frequently, that's another one where you're more likely to swallow air doing that. Chewing gum is a big one. Chewing gum and talking on the phone, again, that combination, but chewing gum, because while you're chewing the gum, you're swallowing saliva, you're swallowing air, and sucking on hard candy. So those are all some of the mechanical reasons. And again, if you're doing this stuff all the time, if you're chewing an occasional piece of gum, it's unlikely to be a problem. But if you're a sort of habitual gum chewer, and you're also finding that you're burping, bloated, and have belly pain a lot, it may be worth evaluating what's going on. And particularly so much of the candy and the chewing gum has artificial sweeteners in it. And that's also going to be more gas producing, although typically that will produce gas in the small intestine and further down. But that's a common cause of flatulence, or these artificial sweeteners. So that can sort of contribute to it. Although aerophagia, technically speaking, is air in the upper part of the GI tract, primarily the stomach. And so unlike other kinds of bloating, for example, if you're eating a lot of artificial sweeteners or you have small intestinal bacterial overgrowth, SIBO or something along those lines, you may notice that more of your bloating is lower down. But the sort of distinct thing about aerophagia is that people will often find, I'm going to stand up a little bit to show you, it's usually right in this area here, higher in the abdomen, in the stomach area, as opposed to lower down. So I would say sort of typically that high belly, like above the belly button, and it will often feel tight because a lot of the air is in the stomach. And remember, the stomach capacity is, stomach's about the size of my fist, expanded, it's about this big. It's not huge. Whereas with the small intestine and the colon, you have several feet of real estate really that can expand. So you can hold a lot more air in your small intestine or your colon than you can in the stomach. The stomach's going to get distended, it's going to get sort of fully inflated, and then you're going to feel it with that sort of tense distension. And typically the way that you would relieve that is you would burp. And when you burp, that lower esophageal sphincter opens, lets the air out, it comes out through the mouth. So people who have aerophagia often have this very sort of pressured burp, right? It's like air coming out under pressure. So we talked about some of those mechanical things, the talking fast, eating fast, sucking on a straw, hard candy, chewing gum. Smoking is another big one, because as you're smoking, you're also taking air in. And some of that air is going into the lungs, but some of it is going into the stomach too, which is why when I do an endoscopy on a smoker, I can always tell, no matter how much they've brushed their teeth, whatever they've done, if they've smoked a cigarette within the last 24 hours, I can smell it when I do the endoscopy in their stomach, because quite a bit of that smoke goes into the stomach. And so I can always tell if somebody has been smoking, if they're a smoker. So these are some of the mechanical reasons. Another big mechanical reason is something called a CPAP machine. So if you have sleep apnea, which is basically while you're sleeping, you're going, there are periods of time where you're not breathing. That's what apnea means. It means the absence of breath. So if you've been diagnosed with sleep apnea and you have been prescribed a machine called a CPAP machine, which stands for continuous positive airway pressure, that is a machine that goes over your face and it forces air down into your lungs to make sure, you know, that they keep a positive flow of air, so that during those times of apnea, when you're not breathing, that's what the CPAP machine does. It alleviates that by continuously putting the air through at a particular rate. And a CPAP machine can be, something that works very well for somebody with sleep apnea. But unfortunately, one of the side effects is that with that forceful pushing of a sort of positive airway pressure, pushing air down into the lungs, some of that air is going to go into the stomach, is going to get swallowed. So people with sleep apnea who are using a CPAP machine, that's a common problem that we see. And then the third category is really people who have anxiety and depression. And depending on what studies you read, some studies suggest that, high percentage. I've read one study said 19%, another study said 30%, but let's agree that a significant percentage of people with depression and with anxiety, in this particular study, we're talking about swallow air, and it's sort of a nervous habit. So when people are anxious, they tend to swallow more. I'm swallowing now as I'm talking about it and thinking about it. And they tend to take those deliberate swallows, not just a swallow that's happening reflexively that you're not thinking about. And I describe that as the difference between a breath and a sigh. So as I'm talking to you, I'm breathing, but I'm not thinking about the fact that I'm breathing. But if I go, I just took a big breath, right? And it's the same with so that's an example of how we pass air out through our upper airway, the same way we pass air through our digestive tract. So we pass a significant amount of air, more than a liter, through our anus all the time, sort of passive diffusion. That's different from a fart where you're like, okay, now I'm going to expel the air, and often there is noise to it, and sometimes there's, a smell to it. That's different from just a passive diffusion of air that is happening all the time through the rectum. And so again, when people are suffering from anxiety, and with depression also, it's been described, although to a lesser extent, there often is this more frequent swallowing as part of the anxiety. And with that swallowing can come some air. Now, some people who have aerophagia are the swallowing can be a coping mechanism where when people are, feeling upset or panicked, they start doing this thing like that again. And I had a patient who did that, not my gentleman, the older gentleman with the 7 minutes of burping, but a patient more recently, just maybe about 18 months before the pandemic, who came in and she had obvious aerophagia where she was swallowing air. I was watching her, but she was unaware of it. It was sort of subconscious. But when I pointed out to her that she was doing it, she was able to stop doing it for periods of time when she was sort of focused on not doing it, and then it would start up again. So there are all kinds of patterns to this, from the sort of basic physiological, I'm sucking on a straw and I'm swallowing a little bit of air. Carbonated beverages, I forgot to mention, I mentioned artificial sweeteners. Carbonated beverages are a big one. I really like carbonated water. I'm a big fan of seltzer water and sort of, I like Perrier and Pellegrino and this kind of stuff. And I'm burpy after, I'm very aware of it. So that's another one. And that's not dangerous. It can be bothersome depending on how much carbonated water you're drinking. So it's something to keep in mind if you're suffering from this. If you have that combination, you're burping a lot, you're bloated, you have belly pain, and it feels sort of high up and pressurized, I would really look at some of the habits. Again, are you chewing gum? Are you talking quickly? Are you eating quickly? Are you talking on the phone and eating? Are you using a straw? Are you sucking on hard candy? Are you drinking a lot of carbonated beverages? Are you consuming foods with artificial sweeteners? These are all really important things to look at. The other huge category are mouth breathers, for all sorts of reasons. So a common reason would be like my older gentleman I mentioned, he had a deviated septum. So if you have had some sinus issues, so you have a deviated septum or you have sinus problems, you have seasonal allergies is a big one, you may be mouth breathing. And when you're a mouth breather, you are much more likely to be swallowing air. And this could be happening at night or it could be happening during the day. So what a common pattern for some people, if they have been drinking at night, alcohol, they're more likely to mouth breathe and snore and also potentially swallow some air there. So the typical pattern for aerophagia, though, is it tends to worsen during the day. And that's because most people, if they're swallowing air, it's when they're awake. So in the morning, not too bad. And then as the day progresses and you're, drinking fast, eating fast, doing all the different things, maybe smoking, et cetera, and swallowing air, as the day progresses, the air builds up. So that is the mouth breathing is a really common one. When I see a patient with aerophagia, and I have one of the things that I'm always looking at in the differential is indigestion and acid reflux. Those are two really common overlapping conditions. And people, depending on where they're having the pain, it can feel like reflux, because for a lot of people, acid reflux is manifest just onto the breastbone, just here as pain there. And that's where you can feel the pressure from aerophagia. And with acid reflux, there can be burping too. So there can be a lot of overlap there. And I dare say that if you go to see most gastroenterologists complaining of this combination of burping and bloating and belly pain, they are going to put you on an acid blocker. I don't think that's necessarily the right path, but that's probably what's going to happen. And I would say most of the people who I see with aerophagia, they've gone through an initial diagnosis of acid reflux. They've been on acid blockers, of course, hasn't done squat for them. And then they come in saying, like, look, either I have, refractory acid reflux, this isn't working, or there's something else going on. And again, when I evaluate them, I'm usually able, if I'm really sort of paying close attention, I'm usually able to observe the sorry, I have to stop doing that. I feel like I'm gonna end up doing it when I shouldn't be doing it if I keep doing it. So let me stop. But you can observe some element of that with a lot of people, and not everybody is quite as deliberate. Some people do it in in sort of a smoother way. But again, for most people, it's inadvertent. They don't mean to be doing it and they're unaware of it. So what I will often do if I feel like somebody has that constellation of symptoms where, to some extent, it's a diagnosis of exclusion, right? Where I'm like, these other things aren't likely. This pattern really looks like aerophagia. Maybe they have a history of seasonal allergies, or they had a lot of issues with sinusitis or even sinus surgery that kind of clues me in. So I send them to my good colleagues, the speech pathologists. And there was a wonderful woman here in Washington named Dr. Susan Miller, who's a speech pathologist. She moved to Florida, but her partner in the practice, Laura Verdun, is still here. Their practice is called Voice Trainer, and I just have to give them a little shout out because they do fantastic work. And, you know, the evaluation consists of primarily close to observation, and they'll have them talk, they'll have them drink, eat, do different things, and they're able to make the diagnosis. And the wonderful thing about aerophagia is that there's no pharmaceutical treatment for this. Yay, no drugs. It really is identifying the pattern, whether it's speech, eating, breathing, whatever it is that's leading to the behavior, and then working closely with the person who's suffering from this to sort of rejigger whatever it is they're doing that's causing the aerophagia. Or it could be a food, you know, it could be too much carbonated beverages, et cetera, and you're just asking them to cut down on those. But it really is a sort of, you know, diet, lifestyle modification. Of course, if your aerophagia is because of a CPAP machine and you have a requirement to use that CPAP machine because of sleep apnea, that can be trickier. But I think for some people, just knowing the diagnosis, knowing what this is, can be helpful. But again, lots of things you can do to treat it. So let me take a couple questions here. You guys ask the best questions always. So is there a vagus nerve connection? There can be, because the vagus nerve, as you all know, is a 10th cranial nerve. When I was in medical school, we had all kinds of like X-rated acronyms to remember the 13 cranial nerves actually. But my dad, who went to medical school, he's 87, so he went to medical school a long time ago. The mnemonic, rather, not acronym, that they learned was on old Olympus, towering top, a Finn and German, vent, 10, vagus, some hop. So 12 cranial nerves. You can tell it's been a long time since I was in medical school. 12 cranial nerves. And that was a mnemonic, but we had something much more X-rated that I can't share with you. But the vagus nerve is a 10th cranial nerve. And that can control movement of the diaphragm. And sometimes there is sort of a misfiring of the vagus nerve, and people can get this repetitive rhythmic burping because of the vagus nerve being triggered. And so that's a little bit different from aerophagia, but there's also a possibility that the air swallowing can irritate the vagus nerve and lead to the burping. So there is definitely some potential interplay with the vagus nerve in some people. So I'm glad you mentioned that. And I got a chance to recite my dad's mnemonic from, he was in Edinburgh doing his medical training. So hence it's got a little bit of a kind of UK twist to it, right? A Finn and German vent some hop. That doesn't sound like something we would come up with in the US. Okay, let's see what else we have. So I'm assuming, Andrew, that you mean when you say patients with CD, you mean Crohn's disease, not celiac disease? Yes. Okay. Thank you for that. Avoid carbonated water, not unless you have a problem with it. I get questions about carbonation all the time. So if you are in remission and you're feeling well and the carbonated water doesn't bother you, no need to avoid it. If you have Crohn's disease and you have fibrostenotic disease, Andrew, you have areas of narrowing, which would primarily be in the small intestine, but sometimes in the colon. Carbonated water, in that instance, the carbonation can build up and create some pressure. So remember, with Crohn's disease, we're going to take a little detour here to remind you that with Crohn's disease, you have three main types. You have inflammatory, where you typically see a lot of ulcerations. That's more similar to ulcerative colitis. You have fistulizing, where you can have little bypass tracts from one area of the intestine to another, or sometimes into other organs. And that usually occurs because there's a narrowed area, which brings me to the third type, which is called fibrostenotic Crohn's, where you have narrowing. So you can be in remission with fibrostenotic Crohn's where you have narrowed areas, but you're not suffering from any bowel obstructions. The contents of digestion are passing through just fine. But if you add to that now, because with Crohn's disease, there's often some rigidity to the intestine, right? There's some scarring. And so the intestine isn't as fluid. Peristaltic movements are a little more rigid. because of the scarring. So even if you're in remission, but you have a potentially narrowed area, let's say you have a narrowed area in the terminal ileum, which would be the part of the small intestine most commonly affected with Crohn's. And now you have a lot of the gas, the carbonation building up in that area, and it's scarred. So it doesn't have that typical ability to distend like a balloon. It's more like a lead pipe. You could see how that could create potentially some bloating. So what I want to say to you, Andrew, is that if the best way to find that out is to try it. So if you like carbonated beverages like me, and ideally this is not carbonated soda, right? This is water and stuff, and you tolerate them fine, then I don't think there's any problem at all with your Crohn's. But if you find that it's leading to some bloating, some abdominal pressure, etc., I would cut back. Okay, hope that was helpful. Oh, thank you so much. Yeah, the drug-free IBD course, I'll tell you, Andrew, the only holdup for redoing that, and we did it at the beginning of this year, and I tell you, I think I had a better time than all the people on it. I had such a good time because we had cameras and I was able to get to know the group. Some of the people I knew were former patients for the drug-free IBD course, and it was fantastic. And it was supposed to be an hour on Tuesdays, but ended up being 2 hours on Tuesday nights, and I was really sad when it was over. The holdup for relaunching it is just me. There are a couple of videos that I have to record, and I've had dental drama, as many of you know. I had a snowboarding accident the end of January that led to a concussion, a cracked tooth, a fractured root, and an emergency tooth extraction after an aborted root canal. And then I had to wait quite a few months for the implant, which I got a couple of weeks ago. So I've had some jaw issues and some facial asymmetry and swelling and different things, but I need to get those videos done. So thank you for reminding me. And and I'm glad you're taking Dr. B's masterclass. That's fantastic. Okay, so from Carrie, hi Carrie, mouth breather from deviated septum, even when running. GI suggested simethicone to break up gas. I do not take. Better suggestions for helping trapped air in intestines. Yeah. I'm very, I don't say I'm anti-pharmaceutical, but I'm for judicious use of pharmaceuticals. Simethicone, not a big deal if you had to take it, but you don't want to necessarily take simethicone every day. And running is another one that I didn't mention. So thank you, Carrie, for bringing that up. I tell you, I'm a mouth breather when I run, probably because I'm a slow runner. I can run far, but not fast. And I feel like I'm always, even if I'm on a slow jog, I'm gasping for air, just trying to get enough air in. And what I found over the years is that I can get more air in breathing through my mouth than my nose when I run. Although I recently read a fantastic book called Breath, or maybe it's called Breathe. I don't remember whether it's Breath or Breathe, but it was a really terrific book. And I didn't think this whole process of breathing could be made so interesting, but the writer, and I wish I could remember his name. Let me look it up really quickly so I can give him a little shout out, because it was such a good book. Breathe or Breath. Or if anybody comes up with it faster in the chat, please put it in. The book is by James Nestor. Breath, the book by James Nestor. And he's a phenomenal writer because he makes this process of breathing so interesting. And he uses himself as an example and, all these breathing patterns, problems he's had. And he talks about his underbite and his mouth breathing. But in that book, he talked about the importance of nose breathing, of rather than breathing through your mouth. And I do a kind of yoga called Baptiste style Vinyasa flow yoga, and we talk about the Ujjayi breath. So in that yoga class, you breathe through your nose, and the goal is to make this Darth Vader type noise, like. And my husband's always embarrassed to be next to me in yoga because I really get into it. I'm going to out Darth Vader the person next to me. Not that we're supposed to be competing in yoga, but I take the Ujjayi breath really seriously, and I make so much noise. He's like, it's kind of embarrassing being next to you. And in yoga, I can do it. But when I'm running, I switch to mouth breathing. But James Nestor in his book talks about why nose breathing, breathing through your nose rather than your mouth, particularly during exercise, is so important and a more efficient way of breathing. And so I've been practicing it out on the trails with my little slow running. And, the other day I was able to run a mile nose breathing the whole time without reverting to the mouth breathing. And I do feel like it's more efficient. So I'm working on it. It's like a little skill I'm developing, but the book is great. So do check it out. So Carrie, I'm going to refer you to James Nestor's book because, he has some really great suggestions in there. And even though you have a deviated septum, you could probably still get some nasal breaths in there, but it is a skill you do have to practice. There are things you can do with, closing off one nostril at a time as you practice and figuring out which is a better nostril to breathe through. But most people, even with a deviated septum, can relearn and readapt to nose breathing. So I think that would, first of all, I would check out his book and I would make that the goal. And then there's some things that speech pathologists can really help with, because Carrie, you're an ideal candidate, right? You know that you're a mouth breather because of this deviated septum. And so really it is relearning these breathing patterns. And I would really recommend, if you're in the area, Voice Trainer is great, but you can look up, speech pathologists and find out if any of them have an expertise in aerophagia, something to look at online, because it's a whole technique they do with the retraining for the nose breathing. So there are definitely alternatives to just taking simethicone every day. Simethicone every now and again is probably not terrible, but I'm with you, like simethicone every day, not so much. Okay. Oh, and Nestor has some great YouTubes as well. Fantastic. That's great to know. Yeah, I was pretty new to his book. I just sort of discovered it and thought it was great. I have to say, as a physician writer, I feel sort of badly saying this, and I have book number 4 coming out in November, The Antiviral Gut. So we'll do a session on that later this summer. And I'm proud of my books, and I think I've done a good job writing them. I was an English major. I've written every word. But as physicians, we're not always as entertaining with our books, right? Where we sometimes are a little medical. And so when I look at a book like James Nestor's book, it's written like I was laughing out loud for some of the stories in the book, especially some of the stories in the beginning. And maybe it's because as doctors, like we sort of take ourselves a little more seriously. We're not as good at just making fun of ourselves, which is sometimes really entertaining. So for book number 5, which I'm planning already, I want the book to be called Dirty Girl MD. And it's about autobiographical, about trying to live dirty in a clean world and sort of straddling those two worlds of conventional and more functional, holistic health, and some of the hilarious things that happen, including like experiments with not bathing, no deodorant. I don't have my little pads on today, all these different things. So that would be a good opportunity for me to just like really make fun of myself and point out that we're all on this journey together, even the experts. All right, what else do we have in the questions? Susan is trying to keep her tongue resting on the roof of her mouth too. So on the top, the hard palate up here. It can be hard when exercising. Do you do this in your yoga class along with the nasal breathing? I don't in the yoga class, Susan, but I do it with the running. This is one of the main things. This is so cool that you pointed this out, because this is one of the main things with my nose breathing, running stuff that I'm doing that I find is I keep my tongue up there like that. And I think my mouth looks funny. I know people must pass me and think, okay, she looks really strange, but it does help. And, that was just something with the nose breathing thing that I figured out, and it really does help. So I don't do it with the Ujjayi breathing. I've been doing this kind of yoga for about 15 years. So I think it just feels a little more natural and automatic. I don't have to think about it with yoga. Maybe I'm doing it, I'm not aware, but I'm very aware with the running of holding the tongue up there like that. So thank you for that. And seems like that is maybe a more common thing that people are doing. Okay. Let me spend a little time talking about the anxiety, depression piece, because, for a lot of people, aerophagia isn't a constant thing. We have chronic aerophagia and we have acute aerophagia. So aerophagia in the setting of anxiety in a more acute setting can be almost like the sensation of having to pee when you're nervous, which is the way my anxiety manifests if I'm nervous. So if I'm about to go live, for example, to give a talk in a big setting at a conference, I will have just gone to pee, and literally like 30 seconds later, I feel like, oh, I think I have to pee again. So mine manifests as a sort of bladder sensitivity. And some people get nauseated, other people get a tremor, some people swallow air. So there are all kinds of ways that that sort of intense anxiety can manifest. And then there's the more chronic aerophagia, which is more sort of that slow burn of, people having frequent swallowing and not so much in a that sort of acute panicked setting, right? And the same is true for depression. So again, it's anxiety and depression. There's a little more written about it in the anxiety literature, but clearly can be a feature of both disorders. Okay. We have something from Carrie. Okay. So any suggestions in general for trapped air in intestines, tea, et cetera? Yes. So the couple things that I like, natural remedies. So ginger and fennel are both great. And fennel tea, you can use the fennel seeds. I like to use a fennel bulb, just get it from the farmer's market, chop it up. And sometimes I'll make a fennel and ginger tea. So boil both of those. Excuse me, see what's happening now? I'm burping all the time. So chopping up some fennel, using fennel seeds, ginger, boil it with some water, let it steep. Drinking that can really help. Ginger is great for motility in the GI tract. And I don't know if you've ever noticed, but certain restaurants, and there's a local restaurant here not too far from where I live called Indique, which is wonderful. And I've seen it in some Persian restaurants also. They'll have a little tray of cardamom and fennel and different seeds that you take after you eat as a digestive. You're not supposed to swallow them, but you can suck on them. You do different things. They're very aromatic. And those are digestive aids. So, this is not new. Lots of different cultures have been using this for centuries, if not millennia, this idea of using things like ginger and fennel and other things to help stimulate digestive enzymes, to help in the digestive process and to help stimulate peristalsis. So Carrie, I would try the ginger and fennel tea and see. And then there are some peppermint capsules that also have ginger oil in them. There's a brand called Heather's Tummy Tamers that I like, that I think work well. And I've used those in a lot of my patients, these peppermint oil capsules. Again, they have a couple other things in them. They have some ginger and I believe fennel. So if, walking around with your tea is not as convenient during the day, you could try some of those Heather Tummy Tamers capsules. And some people have found they work really nicely. I've had a couple patients complain that they actually give them indigestion, but that's been the exception rather than the norm. So I think they're fine to try. All right, what else we got? Okay, let me go to the question and answers. Okay. All right. Question also about what to do if you are having these symptoms and you don't have a diagnosis. Okay, how do you get a diagnosis for this? And I'll tell you that, even in the GI community, there's not a huge awareness around aerophagia. And when I joined the faculty at Georgetown in 97, I was lucky because Susan Miller, Dr. Susan Miller, she's a PhD, was there at this Center for the Voice. And the chairman of the department at the time, Dr. Stanley Benjamin, who is sort of in GI, we're all divided up. So I was an IBD person, and I also did video capsule endoscopy. So I was sort of inflammatory bowel disease and obscure GI bleeding, which was the reason we were doing video capsules. Stan was an esophagus guy and kind of upper GI tract. Somebody else was pancreas. Somebody else was more colonic disease. So Stan Benjamin dealt with a lot of esophageal disorders, issues around reflux and Barrett's disease, which is, again, the precancerous changes in the esophagus. And so because he saw people with all these different sort of esophageal problems and reflux, upper GI tract problems, he also saw a lot of patients with aerophagia. And he had been referring people to Susan Miller for a really long time. So when I came in 1997, brand new, he introduced me to Susan, and we had a great referral source for those patients. So it was as soon as we diagnosed them, we would send them over, and she did an incredible job. Sometimes those patients would end up with an endoscopy, although I'll tell you that an upper endoscopy is not something essential in the evaluation of aerophagia. It's just that if there is a little bit of an overlap, if the patient's complaining of a lot of pain, a lot of distension, and you're concerned that they, maybe there's something going on, maybe they have an ulcer or some obstructing lesion or something, it's sometimes appropriate to do imaging. And that imaging could be as simple as an abdominal x-ray. It could be an abdominal ultrasound, or it could be all the way to an abdominal CAT scan, right? Sometimes bad things like pancreatic cancer can present with abdominal pain and bloating. So depending on what else is going on and things like the patient's age, et cetera, habits. I mean, I wouldn't be looking for pancreatic cancer in a 25-year-old for sure. But in somebody older, and maybe if there's a little weight loss or something going on too, I would. So depending on the clinical situation, and this is where, there's no one size fits all for this stuff. So we do have guidelines, and we do have diagnostic algorithms. If they have this, then do this. If they don't have this, then do that. But at the end of the day, I always say that medicine is an art that aspires to be a science. And sometimes, it's just this sense you have with a person that I think there's something else going on. So, and when you have that sense, follow your gut. It has led me to good places with people, to finding some things that I was very happy to find, and they were too. And so occasionally we are going to end up doing an upper endoscopy on somebody, doing imaging, doing endoscopy, doing a full evaluation, because we're concerned that there may be something else going on. And so with those patients, once we're like, okay, we've essentially ruled everything else out, now we're going to hand them over to Susan Miller at Center for the Voice, and now her practice voice trainer. So I have to tell you, I've been really impressed with the work they've done. I have a patient a few years ago. She's actually a physician, and she was a little complex because she had two things going on. She had small intestinal bacterial overgrowth as a result of super aggressive antibiotics that had happened for various things, sinus infections, a Lyme disease scare, several different things. And she ended up on really accelerated course of antibiotics. I believe there was a parasite in the mix also, with some travel that she'd done with her family. And she had a lot of bloating, abdominal distension, et cetera. And even after we identified the SIBO, the small intestinal bacterial overgrowth, and treated it, and she was really good with her diet, she was already pretty much plant-based, so there wasn't a lot of adjusting with her. There were some things we had to add in, and a few things I wanted her to cut down on, but she was a pretty good eater. But even after we got the SIBO under control, she was still left with a pretty significant element of this. And she ended up seeing the folks at Voice Trainer. And sure enough, she did have some aerophagia. And she was really skeptical when I told her. She was like, no, I don't think that's what's going on. But when they evaluated her, it turned out that there was. And it may have been, this wasn't something that had gone on for a long time. This was a fairly acute situation with her. And I think it was a result of all the other stuff that had happened, that it had sort of changed her breathing, and she had started to develop some aerophagia. So it can be part of another symptom complex. It can overlap with something else. It's not necessarily standalone. It can be acute. It can be, I wonder with, it's not something that has really been described as part of long haul syndrome with long COVID, post-acute symptoms of COVID. But I wonder for some people who have continued to have congestion post-COVID, which is something we have seen, whether we'll start to see some element of aerophagia. But on the list, it's certainly not in the top 50 things. A lot of those symptoms tend to be things like chest pain, shortness of breath, brain fog, fatigue, joint pain, things like that. Although I wonder with the shortness of breath, and the technical term for that is dyspnea, whether there is more kind of gasping, air hunger, people feeling like they can't catch their breath, and particularly with exertion. So, it may be one of those things that will pop up on the radar with long COVID. We're keeping our eye out for it. All right, we have a couple more questions. Any tie-ins to any of the biomes? I'm always looking for a microbiome tie-in. Not a huge one here, other than this sort of SIBO, artificial sweetener, lactose intolerance tie-in, right? So these are all potential add-ons for aerophagia. If you have a tendency to aerophagia and you're lactose intolerant, but you're still consuming large amounts of dairy, as many people lactose intolerant do, you can be adding a little bit of insult to injury there, right? Because you are going to produce additional gas from the lactose intolerance, and that's going to be on top of what you're already swallowing. I talked about my patient with SIBO, and that was happening with her. And so if you have dysbiosis in general, which is a term I like to use, SIBO is a form of dysbiosis. If you have a disrupted, altered microbiome, and you have, it's a simplification of what's going on, but you have overrepresentation of certain species and underrepresentation of others. And we know, for example, with certain types of dysbiosis, you can have, for example, an increase in the methane producing type of bacteria. And in those people, they tend to have slower motility and constipation. So they tend to be backed up in general. Okay. And now if you add additional air coming into the mix, I think that's going to create more problems. But I'm not aware of any studies looking at how aerophagia and the extra air affects the microbiome. But I'll tell you that microbes are very, very sensitive to oxygen content. And I'll give you so for example, in the mouth, we have very different species in the mouth where there's lots of oxygen compared to lower down in the colon. And even overnight, this is, I love talking about BO, right? You probably got that from the last one. So overnight, part of the reason why we have morning breath is because during the day, we are breathing and we are talking and our mouth is open. Even if we're breathing through our nose, there's some element of mouth breathing and talking. And so there's the oxygen content in our mouth, in our oral airway, is higher. At night, ideally, we're supposed to close the mouth, breathe through the nose. And what happens is the oxygen content in our mouth, because our mouth is closed, drops. And so the bacterial population shift overnight to more anaerobes, the type of bacteria that don't need oxygen versus the aerobes. And that shift in bacterial concentration overnight, because of the drop in oxygen concentration, is one of the things that contributes to having morning breath, which we all sort of know as like, not so great, right? Kind of stinky breath. So, if we can see that in the mouth overnight as a result of the difference in oxygen concentration, I wonder what we might see in the rest of the GI tract. Now, keep in mind that the stomach has a lot less microbes in it than lower down in the intestine, right? There's a gradient as you go from mouth to anus. So esophagus, stomach, duodenum, jejunum, ileum, all the way down to the colon and the rectum. The gradient, the amount of bacteria increases dramatically. So high amounts of bacteria down in the lower colon versus up in the stomach. The stomach's not sterile by any stretch of the imagination. But that's such an interesting question. And I love these office hours because I think I learn as much from you guys as you learn from me with these great questions. So I'm gonna look into that. But again, we have the precedent with the morning breath because of the closed mouth and the different oxygen composition. And for example, the bacteria on my face in my nasolabial folds here, which I like to go like this all the time, wouldn't that be nice? And then my daughter tells me that I look like an avatar when I do that and get rid of the nasolabial folds. But anyway, I'm glad to have them because it means I'm getting older and wiser and I'm still here as opposed to the alternative, not being here. So I'm happy to have them. The oxygen concentration in these folds is very different from what's going on a centimeter above on my cheek. And the bacteria that live in your nasolabial fold are completely different from the ones that live a centimeter away on your cheek because of the oxygen content. So we do see that bacteria are very, very sensitive to oxygen concentration. And now, I don't know, the air swallowing, and this is where I'd have to ask some of my chemistry friends. I mean, you're swallowing the same air you're breathing. I don't think that is dramatically changing the oxygen composition, but who knows? I mean, I'm going to look into it. I'll let you know next week. Okay. What else we got? What is the best way to diagnose SIBO? Is an alternative to upper endoscopy? So Jill, we don't diagnose SIBO with upper endoscopy because we can't see the microbes. So typically we diagnose SIBO with a breath test, and that can usually be done at your gastroenterologist's office. But the breath test is not 100% by any stretch of the imagination. So SIBO is still a clinical diagnosis to a large degree, but there is a breath test that can help to diagnose it. And that might be something you want to look into with your doctor if it hasn't been done. And again, not that it's a make or break, test positive, you have it, test negative, you don't, but it can be supporting evidence one way or the other. Okay. Thank you. Thank you. All right. What else do we have? Okay. I took your advice. We have one more. For patients with Crohn's, is it common to have SIBO and Candida overgrowth? If so, is that a concern, or is it best to just focus on keeping the Crohn's in remission? So Andrew, it really depends. If you have been on steroids for your Crohn's disease, and there's a high likelihood of having Candida overgrowth, if you've been on steroids or antibiotics, and I hope you haven't, but often these are drugs, people often use the combination of Cipro and metronidazole for Crohn's, or steroids like prednisone. And both of those things will lead to Candida overgrowth. And if you've been on a lot of antibiotics, it's likely that you could have SIBO. So those are definitely both things that are sort of potentially at play. And again, I hope you join us for Drug-Free IBD in a little bit so I can answer all of those for you. Okay. So I think we are going to end with that. This is really fun. Next week, just a little shout out for next week, we have menopause and microbes. And I don't think you have to be menopausal. I don't even think you have to be female to come to that one, because we're going to really just be talking about how hormonal changes can affect the microbiome. And we're going to be talking about testosterone too. So I want you guys to plan, the men out there, I want you to plan on coming too. And if you don't feel like coming, send a woman that you know, or a girl that you know. So even if somebody's far away from menopause, if they're eventually going to get there. And then the week after, understanding irritable bowel syndrome. So keep the suggestions coming too for other office hours, because those were both, the IBS and the menopause were both suggestions from you guys. And so great to spend a little time with you today. Bye-bye.